So your nerves would actually grow towards the electrode array. So it's kind of a very less gap which you will have between your electrode array and the nerve endings, making it very specific again. So that's one of the techniques which is one of the prototypes again which is being developed, and which will decrease the man-machine interface, make it very specific, decrease our energy requirements, and hopefully will make us having much better options for our patients. The last thing is obviously genetics. Now, almost all well-read patients who come to us for cochlear implants ask if we have a scope for genetics, right? Nobody wants an external device. Just for the matter of, we have a totally implantable cochlear implant now which is being developed. Almost 8 to 10 patients in Australia have undergone a totally implantable cochlear implant. It's still in experimental phase because the battery is a big issue. Many people believe it's not being developed because the hearing aid industry would lose a lot if that kind of an implant comes in. So obviously economics, COVID, economics plays a big role in our management now. And that's why probably totally implantable cochlear implant we are not seeing as of now, which probably would have seen. But genetics would actually again change the role a lot. And we all know it's a majorly genetic thing which we are dealing with. However, in India we don't get a lot of genetic testing, but it's a big role which plays in hearing loss. And if you look at the genetic engineering, it's kind of people are working on adenoviruses which would carry those genes which you want to change and really replace them, insert these things with inside the round window again, so the portal of entry remains the same, and then you expect the genes to change. And majority of studies, so been to Stanford for a month or so, and they're still doing only on rats and chicken. So when my patients ask me, do I have any hopes with genetics, I tell them forget in your lifetime at least. But that's a kind of a very rude statement. But I don't expect anything which you would see genetics coming up in humans in a big way in the next 20 years or so. So important thing here would be that you do your surgery, preserve the inner ear structures. Right? You don't know where the genetics will really work upon. So you want to preserve those cells if at all genetics comes into place. And okay, can I have that video again, please? So this is one of the
In a document, if we suspect we've misspelled a word, we can use the find function to highlight the error and correct it or delete it. Within our DNA, that function is taken on by a system called CRISPR-Cas9. CRISPR is short for clustered, regularly interspaced short palindromic repeats. CRISPR consists of two components, the Cas9 protein that can cut DNA and a guide RNA that can recognize the sequence of DNA to be edited. To use CRISPR-Cas9, scientists first identify the sequence of the human genome that's causing a health problem. Then they create a specific guide RNA to recognize that particular stretch of A's, T's, G's, and C's in the DNA. The guide RNA is attached to the DNA cutting enzyme Cas9, and then this complex is introduced to the target cells. It locates the target letter sequence and cuts the DNA. At that point, scientists can then edit the existing genome by either modifying, deleting, or inserting new sequences. It effectively makes CRISPR-Cas9 a cut and paste tool for DNA editing.
So that's what it is probably going to do. And the first step, however, would be when you are starting your implant program, and I'm sure personally Dr. Parida heading the AIIMS Bhubaneswar place, at least the academic institutions should start off with genetic testing now. We started a year back. We still have the funds required for it are still not in place. We started taking samples from all our patients now and extracting their DNA and keeping it on our DNA banks now. But the first step would be kind of identifying which mutation we are dealing with in our particular area, right? And then we can actually think of correcting it. Now, do we really see it in near future, right? And video again, please. Sorry. Now, 1960s, we had the first experiments where external beams were given for DNA mutations, sometimes successful, sometimes unsuccessful, right? And you had weird results coming out, and that's why it could not be really put into practice. 1970s, we had more methodical and more scientific genetic mutations when we inserted these DNAs, hoping that they would get incorporated in the nucleus by themselves. The first animal, and in fact the animal which requires a lot of regards is going to be mouse or rat, because the animal studies are based on this animal, and now we have many recombinant insulins, growth factors, enzymes which are being used across the world for genetic engineering, especially when we talk about the cardiac part coming up in a big way. In our lives, the tomatoes which we see around us are many times genetically engineered now, and it's having a much more longer life than what others would have. Similarly, many modified organisms are existing, and now we have had surrogacies and other things, and mitochondrial RNAs or DNAs, the cellular DNAs have been changed to get non-mutated kind of DNA inside the next generation, and that's where people are experimenting it on that. We have fish which are much bigger in size. We have these glowing fish, which are the zebra fish, which are used for various experimental studies, again with the help of these gene editing techniques. Now, this editing technique, however, required a lot of money, and that's why it was out of reach for majority. The cost factor has really gone down now. It's much lesser than what it used to be. The number of days required for this was again very huge, which has come down again. So it's not that it is going to be an impossible thing. We will be seeing it, but maybe not the right to tell our patients to keep on waiting for it. And we hope that this would come up in a bigger way, not for the indications mentioned here, but for hearing loss at least, so that we see much better results for our patients. Just ending with this is a 1963 newspaper. When a clipping shows, you will be probably having your phone inside your pockets. Nobody would have believed 1963 this would happen. Now we carry it in our hands and pockets majority of times. So it's kind of like, I think the first mobile phone which I used was in 2004, right? And so for me it was like 40 years. And we're talking about genetics for the last 10, 20 years now. So maybe 20 years down the line, we would really be seeing something which seems impossible right now. Now just ending with this, can you play this video again? Right? We hope that these kids perform in every way possible, right? Not just speaking, not just being able to hear, but being a part of our life in the normal way. Another girl which got implanted, able to understand music now, able to dance now, and going to a good school, schools allowing them admissions. This is what we really look for. Thank you everyone. Thank you everyone, and I hope I wasn't really too boring for all of you.
Thank you so much, sir. It was an excellent presentation. Now I would like to ask Dr. Subrat Behera, sir, to come on the stage, please, and give a small token of appreciation, a memento to Dr. Mohnish, sir. Subrat Behera, sir, is son of Dr. Gangadhar Behera, sir. So we are so lucky to have him here. A clap from the audience. Thank you, sir. Thank you, Dr. Mohnish. Now I request Dr. Anil Das to please come on the stage and please give the mementos to the chairpersons. Thank you, Dr. Mohnish. Thank you so much. Sir, please stay back. I would request Subrat sir to please come on the dais, please. How? Thank you everyone. Can I have a note from the organizers that are we going to start the OT or the next oration? OT. So let's have a, let's connect to the OT please. After OT, after the completion of the case, I think we'll have the OI oration. Madam is already here. So we'll have the next oration. Him in the occasion of the 43rd annual conference. Sir, Rudra sir will accompany Dr. C.R. Das sir. He has been working here since a long time, I think last 20-25 years. Since I was a school student here, I have seen Dr. C.R. Das working here. Now he has popularized ENT in Balasore.
I have a common, some common thing between him and me. We had the same thesis. And he passed earlier than me.
I request sir to felicitate Dr. C.R. Das sir. He's a very good clinician. I've seen personally, he's a very good clinician, and he tells patients that, see, you are not going to get, if you are not going to get operated, you are not going to get cured in CSM cases long back, which has been exemplary, and then patients go to Cuttack, and then we get cases to operate. Now we have become ENT surgeons, that's why. Thank you so much, sir. Thank you so much. We can connect to OT now.
Low control.
So, Dr. Timba Sundarai will be moderator for this session.
Sir, should we start the class now?
Yeah.
Okay, sir. Dr. Is sir. Okay.
Gaurav? Gaurav, this is Chinmay.
Yes, sir. Hello, Chinmay, sir.
Gaurav is not here.
Okay, I will give you my
Interesting. Gaurav is good. You can go and enjoy lunch there. Okay. So you will take your lunch plate and go inside. Chal.
दिखा रहा बोले क्या हुआ नया ना बढ़िया क्या अच्छा 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 ये स्पॉन दिखा रहा तो क्या दिखा ठीक है तो गलती से लग गया भाई
मेरे को कैसे पता ना ना पीएफ से मेंशन करें सर के मतलब तो मानो देख रहा है
भाई फोटोटा बोल के मास्टर बोला
Sir?
endoscope केमती शिकले होता ठीक लिही कहिली चारटा संडे आई विल इन्फॉर्म यू
चैप्टर 1 रो
आकल पड़े मेरा कॉफी धरी पड़े आसी
आज्ञा
कॉफी धरी पड़े आसी एई जो काम
Make some noise, but M5 handpieces are actually very good from the metallic part. Yes, sir. Sorry.
Trained Ormond Street Hospital for Children in London. She popularized the technique of endoscopic dactylocystic rhinostomy in the country. She has 27 years of experience in otolaryngology and is the founder of teleotology services in India in collaboration with Medtronic in the USA in 2013. Her special area of interest includes endoscopic, orbital and lacrimal surgeries. She has published 5 projects on transnasal endoscopic procedures, with current book on ROCM with Springer being the 6th one. These projects include 3 books published by her on endoscopic dactylocystic rhinostomy. First in 2006, the second edition in 2011, and then in the third in 2020 last year. A video series on a variety of techniques on endoscopic DCR in 1999 and an advanced version of the video series of various endoscopic procedures related to the lacrimal drainage system in her publication with Springer since 2021. I welcome you, ma'am, to give the oration. I'd like to invite Subhalakshmi madam and Dr. Anil Das to chair this session. Dr. Subhalakshmi madam, Rautrai madam is presently Associate Professor at SV Medical College, Cuttack, and Dr. Anil Das is Associate Professor at Fakir Mohn Medical College, Balasore. Shah State Branch. Thanks to Dr. Anil Kumar Dash for inviting me here, and Dr. Raj Lakshmi for that nice introduction. I'll be talking on endoscopic orbital surgeries. And these are my financial disclosures. I received royalty from Springer for my book on endoscopic DCR and for the video portfolio. Now, prerequisites for endoscopic orbital surgery, as we all know, is a thorough knowledge of anatomy. Can I have the laser pointer? Ability to perform a good endoscopic sinus surgery and good exposure of the orbital lesion depending on the type and extent. So before we go to the anatomy of orbit, now I can use this one. So before I go to the anatomy of orbital structures, it is important to know the anatomy of crucial structures in relation to the orbit. And as all of us have seen during the ROCM pandemic, that this structure, the pterygopalatine fossa, is the most important structure. So this is the skull which shows the anterior wall of the maxilla has been removed. And that's through this wall, in the posterior wall we can see the pterygopalatine fossa in the green, through which the infection reaches the orbit via the infraorbital fissure, as we can see in this diagram. And then from the inferior orbital fissure, it spreads into the orbit. So this is basic anatomy. Just to revise our anatomy, we know the dimensions, various 24, 12 and 6. The distance of anterior lacrimal, the anterior ethmoidal foramen from the anterior lacrimal crest is 24 millimeter, and from anterior to posterior ethmoidal artery, the distance is 12 millimeter, and from the posterior ethmoidal artery to the optic nerve is 6 millimeter. So these are the basic structures in the orbit: the superior orbital fissure, the inferior orbital fissure, and the lacrimal fossa, which I'm not going into the details of lacrimal fossa, although it has a very detailed anatomy. So the most important structure is the orbital apex. What is the orbital apex? Superior orbital fissure and optic nerve, they both are included in the orbital apex. So this is the orbital apex, and this is the endoscopic picture of the orbital apex, which shows the optic nerve and the superior orbital fissure, and that's the carotid artery. So from the superior orbital fissure continues into the cavernous sinus, like we can see in this diagram, and that is how the disease spreads into the orbit. So what are the challenges in diagnosis of orbital apex pathology? When the patient comes to us, whether we can pinpoint the site of lesion and the structures involved, that helps us in further management of the cases. We know that the orbital apex is a complex structure and diagnosis is difficult. There are basically 3 syndromes: orbital apex syndrome, cavernous sinus syndrome, and superior orbital fissure syndrome. But these are only anatomical divisions, because overlapping between these 3 is very common. So if we look at the orbital apex syndrome, this is the orbital apex, as I just mentioned, the optic nerve along with the superior orbital fissure. So all the structures that pass through these both the foramen, of course the optic nerve in addition, and the superior orbital fissure, they constitute, all these symptoms are because of the structures passing through this. So patient will present with ophthalmoplegia, proptosis, fixed dilated pupil, ptosis, hyposthesia of forehead and upper eyelid because of the frontal nerve passing through the superior orbital fissure, and visual impairment because of the optic nerve involvement. The cavernous sinus syndrome has additional paresthesia of the cheek. Due to that, V2 branch of the trigeminal nerve. The Horner syndrome may be present, and similarly, superior orbital fissure will have the same characteristic as the orbital apex syndrome, but without the optic nerve involvement, though significant variation is involved. So now, basically, that was just, I ran through the details because that's a very vast topic. So we'll be talking about just the endoscopic procedures, orbital procedures that we as ENT surgeons are performing. So these, some of them are management of the inflammatory orbital lesions and orbital decompression, optic nerve decompression, biopsy of the difficult lesions. Sometimes the oculoplastic surgeon tries to acquire a biopsy from orbital lesion from external route, and if it is in difficult area, then it is sent to us for acquiring the biopsy, and the orbital apex lesion removal, and globe sparing orbital exentration, of course, has come up as a new procedure. So if we look at the management of inflammatory orbital disease, चल नहीं रहा, video was not on. I think it's only this. Just fast forward, yes. So this was quite an interesting case of 1 month old child who came to us with the persistent periorbital swelling and edema. The pediatrician used to admit the child and give antibiotics. I think 4 courses were given in 1 month, but the swelling used to recur. And we did then CT scan and found that the ethmoids were involved, and we wanted intervention. But the pediatricians just did not accept that. You can see the osteomyelitic bone piece here and the involvement of the ethmoid and maxillary sinus. So we know that the clearance of ethmoid sinuses in these cases is very, very rewarding, though it's for us a simple surgery. But in this case, since osteomyelitis had taken place, so we did it jointly with the oculoplastic surgeon, and while we cleared the ethmoid sinuses, we can see some pus, not much disease, but as long as the infected ethmoids are there, the orbital swelling does not subside. So some granulations were obtained for biopsy and for culture. Externally, we can see that the swelling is localized, but it never regressed completely, and on palpation there was a thin bone piece. So with the oculoplastic surgeon, we did the lateral canthotomy. They wanted to basically explore the floor of the orbit to see if there is any communication of this bony chip outside with the floor of the orbit. So that's the Elman radiofrequency that is used to give incision into the lateral canthal area, and then a subperiosteal incision is given. The lower lid is retracted and the periosteal flap was lifted up. So there was no communication with the outside, but just some inflamed tissue that was removed and sent for histopathology. And then outside lesion was palpated, and we can see a bone chip that was removed and sent for culture. It came out to be staphylococcal osteomyelitis, and the patient responded well, and there was no recurrence after the surgery. So the next case is orbital decompression. There are multiple indications of orbital decompression, like increase in intraorbital pressure due to any reason, like intraoperative bleeding, trauma, tumor. But this case here is of thyroid orbitopathy. Though thyroid orbitopathy is a medical disease and it is a sight-threatening dysthyroid optic neuropathy, which occurs in 5% of the patients, and the treatment of choice is high dose IV methylprednisolone. Irreversible visual loss occurs in 30% cases if not treated. Non-responders who do not respond to even IV methylprednisolone, medial decompression as well as the lateral decompression is planned. So we can see in these cases the finding is the hypertrophy of the muscles, especially the superior orbital muscle, and in the hypertrophy of other muscles also, leading to an increase in volume of the orbit and traction over the optic nerve that causes vision loss. So for balanced decompression, it is important that both lateral as well as medial decompressions are carried out, but if the proptosis is not too much, then even medial decompression can be done. So all the basic steps of endoscopic sinus surgery are performed. These cases comparatively are easier because there are no polyps and the anatomy is clear. So starting from the widening of middle meatal enterostomy, the uncinectomy is done and all the inflamed tissue is cleared. The lamina is exposed on the lateral wall by removing all the tissue. We've started seeing the lamina praepatia as the cells are cleared, and that's the maxillary sinus ostium, which acts as a constant landmark for us. And going up from that ostium, we remove all the tissue till we can see the bare lamina. All the cells, anterior ethmoid, posterior ethmoid and sphenoid, need to be opened, and that's the opening through the window into the middle turbinate. The sphenoid sinus is opened. That's the superior turbinate. So as we debride the inferior third of the superior turbinate, we enter into the sphenoid sinus. With maxillary sinus in view, it acts as a good landmark for us. So that's the sphenoid sinus ostium we can see, which is widened towards the septum. As Dr. Gaurav was also explaining, that we have to keep the debrider medially towards the septum. So once the sinuses are opened, the lamina praepatia is peeled off and we can start seeing the periorbita. So after that, the periorbita is incised and the fat is allowed to prolapse into the nasal cavity and the locules are broken. The same steps are repeated on the other side. The same backbiter pointed posterior inferiorly to open the maxillary sinus. Again, the sphenoid sinus is opened in the same way by trimming the inferior 1/3 of the superior turbinate. The picture here is quite good. I don't know if it is looking as good as I can see it on the laptop. So the lamina praepatia is peeled off, and similarly the periorbita is incised on this side also to allow the fat prolapse into the nose. Since there are many procedures covered in this, so I have not included the fine details of decompression, how much do you achieve, and we only have to be sure that we stay 1.5 centimeter below the frontal sinus so that the fat does not prolapse and block the opening of the frontal sinus.
So, and then this is the lateral decompression, which is carried out by the ophthalmologist, and they do a little bit of lid correction also, and that's the post-operative picture. Then comes the optic nerve decompressions, though we do it in allergic fungal sinusitis also, but that's not something that we intentionally do. This case here is placed because we could see a very good optic nerve hanging loose into the sphenoid sinus. This is a 22-year-old woman who presented with blindness following allergic fungal sinusitis, which is not uncommon in our practice. All of us see these cases. She was 17 days postpartum. Her vision in the left eye was just projection of light, and on the right side it was finger counting. On MRI we can see massive disease filling all the sinuses. And as we all see, a lot of allergic muck and secretions into the nasal cavity and sinuses. So this is a very short clip to show how we cleared the allergic fungal mucin, and the sphenoid sinuses were opened. This is a very small clip from the long surgery that was done on this patient. That's the sphenoid sinus, and this we can see the optic nerve. See, that's the hanging. This is the optic nerve hanging into the sphenoid sinus. It was bare optic nerve, and as the fungal mucin was cleared, it was visible. And post-operatively, her left side vision improved from projection of light to finger counting, and right side from finger counting to normal vision. So these cases are generally rewarding, but it is not the case in cases of optic nerve decompression. There are various indications, contraindications. I am not going into the detail. I am just showing this one case of a 14-year-old boy who presented with a road traffic accident and had multiple fractures, ptosis and vision loss. And this is the repair that has been done on him. And on CT scan we can see multiple fractures in the zygoma in the frontal sinus, and we can see the this short process, the smaller wing of the sphenoid, which has a fracture, and this segment is actually cutting the optic nerve, impinging on it, and these are also multiple fractures. So we were not hoping much recovery in this child, but we still went ahead and explored, and we found that there were multiple fractures. The optic nerve was almost mutilated, I can use that word, and we did the same procedures, same steps of endoscopic sinus surgery. That's the maxillary sinus ostium, which is widened, followed by a complete uncinectomy. The ethmoids are also cleared. The lamina, the ground lamella is perforated. And then we've started seeing the superior turbinate, that's the sphenoid sinus. So inside the sphenoid sinus, this portion of the optic nerve which is inside the sphenoid sinus looks okay. This wall between we've started seeing the optic nerve there. The wall between the posterior ethmoid and sphenoid is broken, and that's the optic nerve. This is the optic nerve which has been sectioned at one place completely. So that's the exit of the optic nerve from the orbit. This is the optic nerve. There is an indentation there, and it seemed like almost complete transaction had taken place at this particular site. And now this is the site of entry of the optic nerve into the sphenoid sinus. So we can still see a bone chip there, and this inside portion of the optic nerve looks normal, but here this is edematous, and that's a bony chip there. So any bony fragment over the optic nerve is first dislocated gently and is then removed without twisting. So that's the periosteal elevator.